The first thing I would say to somebody, and this is another thing that people can use if they find themselves in this situation, is thank you for telling me. Thank you for telling me. And I think that opens the door for conversation. I tell a lot of my patients, a lot of them get caught up in diagnoses, like a label. So I talk to my patients a lot of the time about, you're not your diagnosis. Let's figure out what we need to do to treat the symptoms that bother you the most. Let's figure that out. Let's figure out what we need to do to get you back to the things that you love doing. But let's not focus on this label. Let's not focus on this diagnosis. I'm a big believer that faith and mental health are interconnected. So I think the best possible solution would be utilizing both of them. I do believe that just like in the church we have tools like prayer and confession and fasting, there are tools in life that we have like therapy and medication and treatment that can also help us. And so I don't think there's any reason why we should be neglecting that. Also, the most Christian thing we can do is to help somebody get the care that they need. One of my specific prayers that I pray that I can be a vessel of support for these patients and be what they need to help with their care. And I think that is something that helps me with this job too. But really think that I see so much of God within my patients, and that I couldn't imagine not being a faithful person doing this kind of work, because I do see so many hard things.
What if ancient scripture held the key to our modern struggles? What if our pain was the starting point of God's greatest work in us? What if God's word wasn't just something we read, but something that reads us? Welcome to the Bible Chat podcast. I am your host, Alina, and I am honored to interview theologians, therapists, and compassionate guides from across the Christian journey to explore these questions and more. Today, I am honored to welcome Yianna Papadeas, a passionate advocate for mental health and a dedicated psychiatric nurse. At just 29, Yianna has already made a profound impact through her work in inpatient psychiatric care, including high acuity and forensic units. She provides mental health education through her Instagram page, Dynami, and shares candid, humorous moments from psychiatric nursing on her other page, Overheard in Psych. Yianna brings compassion, faith, and expertise to her mission of bridging the gap between mental health stigma and faith. In this episode, we explore her remarkable journey, the intersection of faith and mental health, and the vital work of supporting those in their most vulnerable moments. This episode, like all others, is a humble effort by the Bible Chat app to share stories of faith, resilience, and service, pointing to our loving Lord in a world yearning for hope and healing. Thank you for joining us, and please enjoy. Yianna, welcome to the Bible Chat podcast. I am so grateful to have you here, and I've known you since you were probably 6 years old or so, and you are doing so many amazing things at your age. I've asked your permission, and I'm going to share with our listeners you are 29 years young.
Yes.
And you've been doing a lot of amazing things, and you are currently doing a lot of amazing things. So I know you will be an inspiration for many young people, and you are an inspiration to me. So I am going to start by asking, who is Yianna Papadeas?
Yeah, well, first off, thank you for having me. I'm very excited to be here and talk about a lot of these important topics that I think should be discussed more often, starting with us. Starting with me and who am I, and a little bit about my background and how I got into the world that I'm in currently. I got my Bachelor of Science in Psychology and my Bachelor of Science in Nursing, both from Loyola University Chicago. And I knew right away that I wanted to enter into the inpatient psych world from when I was in nursing school. It was just the clinical that clicked for me, and I really just found myself having a very big passion towards. So it was history from there. I just pursued it right out of the gate, right when I finished school. And I have experience working as a charge nurse in residential, inpatient across the lifespan in the hospital setting, as well as in the forensic psych setting. So I'm currently pursuing my master's for my psychiatric mental health nurse practitioner here at Regis University in Colorado. And that is my next step towards being able to be more autonomous with my patients. And instead of just carrying out treatment plans, I will hopefully be able to, once I get my NP, be able to evaluate, diagnose, and treat the patients, and really get to do everything from the bottom up with their care from start to finish, from when they get admitted to when they get discharged. And so that's a little bit about my background in terms of how I got educationally to where I am in practice.
That's awesome. How long have you been practicing psychiatric nursing?
Since 2021.
Okay,
Yeah.
so that's 4 years?
Yeah.
Yeah.
Mm-hmm.
When did you know you had a calling for psychiatric nursing?
Yeah. So, loaded question. I feel like I've had a lot of different experiences that really pointed me in the direction. I had an experience in one of my clinicals in Chicago where I had a patient who had been admitted for a self-inflicted gunshot wound. And the patient, I didn't know at the time, was mute upon admission and was not talking to their care team for about 8 months. And I, as a new little nursing student, didn't know what was going to happen in the psych unit, didn't know anything I was doing. And I just, as a nursing student, wasn't allowed to pass meds or anything. And all I could do was really talk to patients. And I sat and had a conversation with this lady for about an hour. And I went back to my post-clinical debrief, and the whole care team came in, the doctors, the nurses, my clinical instructor, and they were like, oh my gosh, what did that patient say to you? And I was just confused as to why they were all freaking out. And I was like, isn't this normal? Aren't the patients supposed to talk to us and tell us why they're here and what's going on? And that was when I found out that it was the first time she had spoken and she'd been admitted. And not only that, it was the first time that she had admitted to the self-inflicted gunshot wound, admitted that she needed some kind of help, some type of care. And it was the first time she had taken any real step towards making any type of progress in her care plan. So looking back, I didn't really understand at the time, but it was a very big breakthrough in her care. And that was one of the first moments I had in my younger life in the school setting of, wow, I think this is what I'm meant to do. And I couldn't really exactly put my finger on why, but I just felt a calling towards it. And I felt that I could really get through to these patients in maybe a different way. And from there, I was like, this is just what I'm meant to do. And then I've had different things over the years happen. I've been in the vicinity of different suicide attempts happening. Unfortunately, one was in Chicago when I was living in Chicago, and then one was when I was in New York. In Chicago, I was on my balcony outside of my apartment showing my cousins that were visiting the view, and somebody had attempted suicide off their balcony. And when everybody else kind of had been freaking out, I was one that had called 911 and was able to remain calm in that situation and focus on the person and the patient and, hey, let's figure out what we need to do for this person. And the same thing happened in New York. I was in a building in New York touring, and somebody jumped off the balcony right few feet away from me, and there were multiple security guards in there, multiple people, and nobody took action. And I was the one that was directing traffic. Hey, we need to do this for this person, called the ambulance and all these things. And there's many different ways to react to that situation.
Course,
and none of them is wrong. I just feel like it's part of my calling to react a certain way and provide the care that these people need when they're in their most vulnerable situation. I think that's why I'm able to do the job that I do as a charge nurse and be able to put the patient first above my own emotions, maybe for those high stress situations. So I feel like I've had a lot of things like that happen in my life where I don't feel like it's necessarily a coincidence that I was in these places at those times, that things like that happened.
Absolutely. What is a charge nurse?
Yeah, so a charge nurse, depending on the facility that you're at, is basically the person that runs the unit. So I'm basically in charge of making sure my patients get their meds, making sure the unit runs well, that the groups are happening, that the doctors are getting to see the patients they need to see, but also most importantly, if there's any type of incident that occurs, any type of self-harm attempt or aggressive attempt or anything like that, the charge nurse is in charge of really running the unit and making sure that everybody needs to be in the place that they need to be in and basically calling all the shots for how we handle that incident. So that can be one of the most stressful parts of being a charge nurse, but I also think it's one of the most important pieces of being a charge nurse because I've seen it go a lot of different ways just depending on people's styles, and it's really important to keep both the patients and the staff safe. Really believe in both of those pieces, keeping the patients and my staff safe.
Yes.
And so I'm really passionate about being a charge nurse
I love that.
in that way. Yeah.
I love that. I think you do amazing in emergency nursing as well.
Oh, I do think psych is a lot of emergency nursing, that maybe people don't know that because they don't really know what is entailed in inpatient psych.
Yes.
But I deal with a lot of emergent situations on a daily basis. So
Yes.
Yeah.
So tell me more about what does high acuity unit means and what does forensic unit means?
Yeah, so acuity is basically the level of supervision and resources that a patient will need stabilization-wise. So we figure that out based on certain factors, their self-harm risk, their aggression risk, how well they're able to complete their ADLs, which is their activities of daily functioning. So a higher acuity level, there's going to be more intense monitoring, more staff resources available, and more watching of the patients, more observation. A lower acuity level unit, there's going to be more independence for the patient because they're more stabilized, not as high a level of observation. It's a little bit more of a low-key unit. easier way for me to explain it.
Sure, that makes sense.
So like the hospital I work at now, there's 2 units right next to each other. One's higher acuity, one's lower acuity. And a lot of times we'll have people start out on a higher acuity unit, and then once they get a little bit more stabilized, they'll be moved over to the lower acuity unit, which is always a nice goal progress-wise in treatment. Patients get over to the lower acuity unit and have more independence. Forensic is a very specialized psych unit. It's actually one of my favorites, but it's when patients are deemed incompetent to stand trial by reason of mental illness or insanity. So they come to me from prison. So they have certain charges of typically like felonies of some kind, and they come from prison to the forensic psych unit to go through what's called restoration treatment, because everybody's entitled to understand the legal charges that are being brought against them. But if somebody is mentally ill and they are not knowing what's going on, can't participate in their own defense, and they can't understand what charges are being brought against them, they need to go through that restoration treatment. And that can take months to years. That can be a very long process depending on how the patient is presenting. So that's a very different type of psych nursing specifically. I think it's really challenging to me, which is why I really liked it. And I think I'll try and find my way back to forensic nursing at some point, but it's very different than regular inpatient psych.
How long have you worked in a forensic psychiatric unit?
So I'm not currently doing forensic psych right now, but I did for about 7 months.
I see.
Yeah.
So what do you hope to do as a nurse practitioner?
The main thing is I want to be more autonomous with my patients. I want to pursue more than the leadership role I'm already in. So right now I have the providers that are already making the treatment plans for my patients, and right now I'm carrying those out, which is fine, but I want to be the one that's evaluating my patients, diagnosing them in them, coming up with the treatment plans, and coming up with a plan of care for how are we going to get them stabilized, how are we going to get them better, how are we going to get them back to whatever it is that they want to get back to, whether it's their family, their job, just whatever their life is. And I want to do that from start to finish. I get to take care of patients from admission to discharge as it is, but I, as of now, don't have a say in their treatment plan as a registered nurse. So I have to be a provider in order to do that.
Do you think it's true when, we hear people say all the time, in America, we over-medicate. Do you think that's true in the psychiatric world?
So I think it can depend. I think I've seen it go both ways. I think there is a big benefit with medication when it's used appropriately. There can also be a con of using it if it's not used in the right way. It really just depends. But at times I have seen people be over-medicated. And as I've seen medication be the difference between somebody being stabilized and not stabilized, and the difference between them being able to lead the life that they want to lead. So I've seen it go both ways. And I think it really comes down to a lot of factors: the provider, the patient, the willingness people have to participate in their treatment, and the things that they're willing to try. I do believe in holistic treatment, so trying a lot of things, not just medication. So there's a lot of things that can be used appropriately and differently that are not just medication. So I've seen it go both ways, but that is a big question, I think, in today's society.
Yeah. So. Well, we are here at the Bible Chat podcast to also talk about this intersection between faith and science and mental health. And I wanted to ask you about this whole idea of just pray about it. I know that, people struggle sometimes with depression or anxiety or suicidal thoughts or all kinds of difficulties. And then we hear this, just pray about it. Tell me how you see that as a psychiatric nurse.
Yeah, so I'm a big believer that faith and mental health are interconnected. So I think the best possible solution would be utilizing both of them. I do believe that just like in the church we have tools like prayer and confession and fasting, there are tools in life that we have like therapy and medication and treatment that can also help us. And so I don't think there's any reason why we should be neglecting that. Also, the most Christian thing we can do is to help somebody get the care that they need. And I think that's the best way to support somebody, whether it's yourself or a loved one. And so I think having more of these open discussions about how to incorporate both of those into our lives is very important and can actually really help people in a more meaningful way. I think that phrase, just pray about it, is not with ill intent when they say it. I just think it's a little bit misinformed because it makes people feel like they're not doing enough or their prayers are not good enough to be answered or get kind of invites some shame in on that person of why am I not enough to get the help that I need if I am praying very, very hard about this?
Why am I not getting better, probably, too. Yeah.
Right. And so I think there is a lot of strength in prayer, and I very much so believe that. I've seen the strength of prayer within my own life with a lot of different situations. And I also believe that there's a lot of strength with different therapies, different medications, and it differs per person. But I think in an ideal world, being able to conjoin both of those would be best case scenario, and utilizing all those tools of the church and utilizing all those tools of medicine and science that we have available to us to support the type of life that somebody's wanting to lead in order to be their best self.
Yeah, thank you for that. You know, you and I were talking about what would a trauma-informed church look like. And I don't think we talk enough about these things in church. Do you have any thoughts on that?
Yeah. So I think a lot of priests are very good at listening, and I think that's a big step. I think listening allows space for healing in general. I do think that, unfortunately, sometimes people, again, have good intentions, but maybe say the wrong thing because they don't want to say nothing. And I think sometimes if you're out of your scope of practice, like we say in medicine, refer out. And so I think if people have the humility and the understanding to say, hey, I don't know what you need to deal with this situation, but let me find out the answer for you. Let me find somebody that can help you appropriately. That to me aligns with a trauma-informed church. This is not my realm. I don't know exactly what to tell you, because a lot of those times where people seek out priests or pastors with very vulnerable situations, it can make all the difference what is said in those moments of disclosure, whether or not somebody seeks the care they need or not. And so it doesn't need to be some long explanation, but if it's, hey, I'm here for you, I don't know the answer, but I can help you figure it out and point you in the direction of somebody that can find you the right resources, or I'll help you find the right resources, I think that is very trauma-informed leaning and would be on the right pathway to being trauma-informed. Also, another idea would be just having church leaders be informed and educated on basic red flags for different things like suicidal ideation or different things that they could see in their congregation of things to look out for, so that if they do see something that's a red flag, they can, again, look into the nearest resource to help try and provide that person with the type of care and support that they need.
Are you familiar with a camper?
Oh, yes.
Psychologists, therapists are gathering, and I know they have amazing conferences.
Yeah, I've been to one of them.
You have.
Yeah, it was
That's
great.
amazing. It would be amazing if you did the presentation and talk about this stuff.
It's on my list.
I don't know if there are many psychiatrists in the organization. I'll have to look. But I just realized that actually is a very good attempt to create trauma-informed churches and to provide resources. And I know for sure they have a lot of good materials about this stuff.
They have a great social media platform, too, as well, that I think shows some great content of things that we're talking about right now. You know, basic red flags, short, concise explanations of things to look for. You don't have to go through all the school that I went through to know the basic red flags of things that you should be looking for in others within your community and your family and your friends in order to be supportive and helpful with these kinds of topics, which I'm trying to convey to people as well through my own platform, is that you don't have to do what I do to be a part of this conversation.
Yes, absolutely. But speaking of your own platform, I would love for you to share with us about Dynami and Overheard in Psych.
Yes.
Tell us all about that. This is all good stuff.
Yes. So I started Dynami, I think in 2020. I like to read a lot of different things, but I had all these notes on my computer, and I was just going through of all the psych books I've read just on my own time, and I had all these notes, and I was like, you know what? This needs to go somewhere. I need to do something with this. And I just feel very passionately that the gap between what I see on a daily basis and what people think a lot of psych things are, I think that bridging that gap comes down to education. And I feel like that's what sparked the idea of creating this platform, of just kind of trying to explain from my point of view as a psychiatric charge nurse what I see on a daily basis and bringing that to the public. Hey, these are what these things actually are, and this is what's going on, and this is what I see on a day-to-day basis. These are the things we should be talking about. This is not what this is in the psych unit, because there's a lot of like negative stigma and a lot of things that just want people to be terrified of psych diagnoses, and that just adds and adds to the negative stigma around it. And so that was kind of the idea of bridging that gap, opening the conversation about it, and creating a safe space and community for people to bring their questions, comments, concerns, their own kind of experiences and for us to just have this platform to be open and talking about it from somebody who's actually on the inside, on the front lines every single day with my patients, and I actually get to see what's actually going on and that to the public. So that's kind of what inspired the Dynami account, and that's the Greek word for strength, a testament to my Hellenic roots.
Tell me about your logo.
Yes, so my logo is a phoenix.
Yes.
And it has a fire burning through it. One of my Greek friends actually is a graphic designer and helped me with the logo. Thank God, because I'm tech challenged. But it's beautiful. It's, the idea that...
Is that Matthews
Yes.
Pulon?
Yep. Shout out to Matt. Thank you, Matt.
Yes.
He's great.
Isn't he the graphic designer for some big...
Avalanche and the Nuggets. He's awesome.
Pardon us.
Yeah. So he helped me do that, and he actually helped with my other one too, which I'll tell you. So the idea with the phoenix is that it represents rebirth and that the end is only the beginning. And that is something that I find to be very true with Psych and dealing with my patients that have a lot of their biggest struggles when they're coming into my unit, and witnessing a lot of their struggles. I see a lot of their strength within their struggles and seeing what they work hard to accomplish while they're in my care. And so I think the phoenix really personifies everything that I see and witness on a daily basis with my patients. So
that's beautiful. And what's the other account?
Yeah, so my other one I just recently started. It's called Overheard and Psych. And so that is more of a satire account. And I joke around with people that nurses in general, but especially psych nurses, we have a dark sense of humor. And it's kind of like sometimes the only way to get through the day because we see some crazy stuff. So over the years, I would always write down funny things my patients have said to me, just out-of-pocket things that are just wild. And so I've had for years just this long list of all these funny things that have either happened or been said on the unit. And again, I just was going through it one day and I was like, this would be some really funny content. I think that's just people would enjoy. And so that is what got me to bring about the idea of Overheard and Psych. And the logo for that is just a brain with Overheard and Psych on it. And it's got a great response so far. I think also, unfortunately, the negative stigma with working in Psych is that I always have like a certain type of patients, or I'm always dealing with like high stress things, which I do deal with a lot of high stress things.
Of course.
But also like most of my patients are so funny. They're so funny and they're so fun to be around. And I love that I get to sometimes just hang out with them, especially when a lot of them get more stabilized. And they just say the funniest things. And so that account has really been, I think, very cathartic for myself and a lot of my coworkers, and just therapeutic and healing. And I think to be a nurse, you need a sense of humor.
To the critics who are not making fun of psychiatric patients, it's just sometimes they say funny things.
They say funny things.
Yeah.
And it's part of the job, and I love it. So, yeah.
Thank you for sharing. I've been following you from day one on Dynamis, and I've learned a lot. So thank you for sharing. And I think I'm even responding to your Overheard and Psych. Sometimes I'm not sure if I should cry or I should laugh. It's the reality of life, and it's hard, but sometimes having a sense of humor, it's helpful for sure.
Yeah.
Give us some stories about what have you witnessed in the psychiatric ward? Some hopeful stories of healing and success stories.
Yeah. So I always have this one that comes to mind because I don't get to see somebody go from all the way from their lowest to all the way back to their most stable point. That doesn't happen a lot. So I'll never forget this patient. It was when I was practicing in California, and she was found as a missing person in the park. And she was around, I want to say, in her mid-30s. And they found her in the park covered in her own urine and feces. And the police brought her in, and we had her for about, I want to say, 3 months, which is a pretty long stay for inpatient psych. Typically, we have our patients for a 72-hour hold, and then that can get extended. And out in California, it could be extended 1 to 2 weeks. So 3 months in an inpatient unit is atypically long. We had her for a while. It was around month 2. She started getting more stabilized on her meds, and we couldn't figure out her name, nothing. She was also one of the most aggressive patients I had. So we had to have a lot of emergency medication situations with her, a lot of restraint situations with her. But once she started to get stabilized on the medications, she started remembering who she was, remembering where she came from, who her family was. We were able to figure out what her name was and how to get her back to her family. And so long story short, it turns out that she was a wife, a mom of 3 kids, had a job, and she just stopped taking her meds. She was diagnosed with paranoid schizophrenia, stopped taking her meds. And on her meds, you would never know that she was diagnosed with any type of mental illness. And so I was there the day they discharged her to her husband and her kids. And it was just a surreal moment getting to see and be a part of her care from point A all the way to point Z of just the difference between all the progress that she had made. And she definitely struggled a lot, and it was a big thing to go through for her, emotionally, physically, everything, and for her family as well. But getting her back to her family, she was a missing person. Her family didn't even know where she was just a very surreal moment that's honestly kind of hard to describe. So, yeah.
That's great. I'm sure sometimes you can even lose your children in those situations if you don't have a husband who cooperates, and maybe they can report you to the authorities and say, look, she's in the park and not able to care for her children as a mother. Probably you can. Do you see that kind of stuff where
Yes. Yeah.
parents lose their...
I see a lot of things with like conservatorships, which is where somebody has legal power of attorney over somebody's medical rights. My favorite is not working with the adolescent unit because there's a lot of stuff with child protective services and DCFS and all that. I've worked with kids, but I personally don't like working in the kids units for that reason. I love working with kids, but it's a lot of dealing with abuse and child protective services, and a lot of times you unfortunately have to discharge kids back to poor situations, and it breaks your heart because a lot of the kids would rather stay in the hospital, and it's like tears you apart. So I don't like the kids units for that reason.
I haven't even thought about that side of psychiatric care. That's
it's
sad.
Tough.
That is so sad.
It's very tough. Yeah.
Well, September is
Suicide Prevention Month.
Let's talk about that.
Yeah.
It's a big issue, and I don't think there is anyone alive on this planet who hasn't heard of someone committing suicide or knows of someone that knows someone that committed suicide. And both you and I do life in very large communities, our Greek churches, and we know a lot of people. And once in a while you hear about someone committing suicide, and of course it's heartbreaking. And I've always asked the question, you know, it's wonderful when the community comes around the family, and we, of course, show up for the family and the care and the compassion and the support. And I always wonder, where were we before that happened? And I want to talk about what can we do as a community, and maybe what can the family do if they see any signs. What are your thoughts on this?
Yeah, I think it's a great topic that needs to be talked about, and I think a lot of times people want to help, they just don't know how. And so I think that's why we should be talking about these things. There's a few things that people can do, and they just don't know it. So I think the first is being able to talk openly about this topic. I think there's a misconception that people get scared that if they talk to somebody about their potential suicidal ideation, that it's going to kind of, quote, plant the idea in their head. It's actually not the case. They've done a lot of research that shows that when somebody's able to actually talk about what they're feeling with somebody who's open, non-judgmental, and being able to have an honest conversation with them about how they're actually feeling, it actually decreases their chances, because then they feel like they're actually able to disclose to somebody how they're feeling, and it reduces that amount of shame. It doesn't fix everything, but just allowing somebody to talk to one person and a little bit get it out of their head of what's been going on actually increases their chances of seeking help, increase their chances of seeking the right type of care. So I think the first thing would be talk openly about it, and don't shame somebody if they do come to you about it, because that can just add fuel to the fire and does not help the situation whatsoever. I think there's a misconception as well that in order to support somebody, you need to understand what they're going through. I wholeheartedly don't believe that. I have patients on a daily basis that I cannot relate to what they're going through, but it's not about me. That's, I think, when people have that mentality, that's making it about themselves, and that's not being supportive. You don't need to relate to what they're going through. You don't need to ask questions like, well, why do you feel like that? That just increases people's levels of shame and not wanting to open up to somebody about it. You just need to be there to listen and non-judgmentally be there for them. And it doesn't matter if you relate to what they're talking about or what they're feeling, just be there for somebody. Like, that makes all the difference. And I think that's one of the reasons I'm very good at my job, because I am not making it about myself, not making it about how I'm feeling or anything else. It's about what is a patient feeling? What does a patient need? How can I best support my patient in their vulnerable moment? I think that is something that can be very much translated into the everyday world when it comes to topics like suicide prevention. So I think that would be the first thing, is talking openly. I think as well, when it comes to your loved ones, your friends and your family, knowing what their baseline is. And by baseline, I mean, what are they like on a normal day-to-day basis? Nobody's going to know that better than your family and your friends. So if you're noticing mood changes, appetite changes, sleep changes, anything different, even if you think it's not that big of a deal and you notice it consistently, check in with them, say, hey, I noticed this was going on. you want to talk about it. And if they don't want to talk about it, just let them know that you're there for them. I'm here for you. If it really is getting to the point of something's very concerning, have the courage to contact emergency services if it gets to that point. I think some people don't take these crises seriously enough, and they're like, oh, they maybe said they're feeling suicidal, but they don't mean it. Always take somebody seriously when they make a statement like that, I think would be another big thing. And always taking action and having the courage and strength to do that, and then knowing the resources that are available to you. Calling 988 or even texting it is a good suicide crisis lifeline that's always available, and you can even report it like anonymously. You can always call for a wellness check as well, which is a big thing. That's not calling 911. That's calling for somebody to check on a loved one without it being as emergent as calling 911.
And what do you call that?
So you can call your local police station.
Oh, wow.
Depending on like where the person's located, and just say, hey, I'm worried about this person. Can you stop by for a wellness check? You can call for a wellness check anytime, anywhere, any state. And that's a resource that's available to people. And maybe they need help, maybe they don't. But I think it's just a good option to have for people to know about that exists.
And the police is trained to come to your door?
Depending on the resources available, they will... There's low resources on this, but sometimes in the good scenarios, they have a mental health professional trained specifically for it that will accompany the officers with them. But most officers are trained in mental health crises. There's always more to be done with that. But hopefully in the good scenarios, they try to send out a mental health professional with them for the mental health and wellness checks. But it's just another good resource and option to have available to people if they're worried about somebody.
What else can be done?
You know, just connecting with somebody, again, just making sure that you make them aware that you're there for them, and not kind of what we say in nursing, passing the buck is like here, like kind of just pushing something off onto somebody else. Making sure that you are referring and helping them with the resources, and not just saying, here's this resource, call this line if you're feeling suicidal, and then leaving it at that. People in those situations need the love and help and support. And in that situation, being like, hey, I'm here for you. We can call them together if you want. I'll go with you to this
companion
clinic.
Them. Be there for them.
Be there for them. Support them in the best way that you can. And again, just overall, just being as non-judgmental as possible, I think makes all the difference.
Is it possible that sometimes families see signs and they are either afraid to acknowledge them or don't want to make it worse or something, you know, and they kind of like ignore them?
Yes, 100%. I have patients all the time who come in on suicide attempts, and when we get collateral information from the families, a lot of the families, and this is not to knock anything that the families are doing right or wrong or anything, it's just the reality of the situation of what it is. A lot of the times it'll be like, well, I never noticed anything going on with them. I never saw anything wrong. I genuinely believe people are saying that truthfully. I think a lot of times, a lot of it is just subconscious denial of they're okay, they're fine, they just are going through a rough patch right now, or they're just whatever the justification is. It's not ill intent. It's not, you know what I'm saying? It's not, they're not misinformed. It's not ill intended. It's just, I think, a human reaction to want to help somebody make everything okay and make everything better, and everything's fine. Like, of course, they wouldn't be suicidal. It's fine. Everything's fine. I think that's a normal human reaction, especially for somebody that you care about.
Yes.
And it's way scarier to say, I think they're suicidal.
Yes.
That's a very big, bold statement that comes with a lot of fear.
To say
and a lot
loud.
of like, okay, wait, what next? But if you think about that, how scary do you think it is for somebody who's feeling that way to say that out loud? You know, and that brings me back to my next point of that's why it's so important for us to be able to have these open and honest conversations with somebody who's feeling that way, because sometimes the first step of somebody that's feeling suicidal is just being able to say it out loud to somebody and not being judged for having that thought. And that can be the first step to getting the care and the support that they need. So that happens, unfortunately, and a lot of family members are kind of in the dark. Like, I had no idea. And of course, if they knew, they would 100% support and love the best way they can. But again, that comes back to educating people on what you need to be looking for. So the more people know about what you need to be looking for, then we can be more preventative when it comes to helping somebody way before they get to the point of a suicide attempt. So,
yeah. I don't know if you had any plans to do this during the month of September, but maybe we should do an Instagram Live.
Yeah.
from Dynami
Okay.
to the Bible Chat podcast and talk about this stuff because
Yeah, I would love that.
people don't know what they don't know. Yeah, it's very interesting because you hear people like Robin Williams never think they would even
Right.
have a problem, you know,
Right.
and I was like, wow, how can you hide it so well?
Right.
And nobody really recognized any signs in them, or they really hid it so well. Can people hide it that well that nobody would ever...
You know, I think people can hide it very well to people that don't know them. But I would be curious to know the people that were close to them in their life. I wonder what they would say. I wonder if they would know what their baseline was and what differences they maybe saw or did not see. And I don't know. It's hard for me to speak on that because of I think it's difficult. I think some people do hide it really well, and that's the way that they cope. But I really do believe that with every single person, there's at least one warning sign. And I think that we just need to educate ourselves and others on what those are and what we need to look for. And we need to notice them. And when we notice them, do something about them.
Yeah, be more brave and courageous and
Proactive
educated and
yes.
proactive. And do you have a lot of people with attempted suicide on the units?
Yes.
So what's happening? What's the treatment? I know this is a dark subject, but I think it needs to be discussed. Like, what's the treatment? What's the hope? What's happening?
Yeah. So it depends a lot on their history. Is this their first attempt? Is this a second or third attempt? What kind of things are we dealing with in their background? Do they have a history of trauma? Do they have a history of substance abuse? You know, what are they coming into the unit with history-wise? And so I think a lot of their history helps determine their plan of care and how we're going to help them. What kind of risk factors do they have? What kind of protective factors do they have? Risk factors would be like what I just mentioned, a history of trauma, a history of substance abuse. Protective factors would be something like close family support system, high in spirituality, good positive coping skills would be protective factors. So that's one of the first things we do when we admit someone is we identify those risk factors and those protective factors of how we're going to help best with their care. A lot of times too, it comes down to have they ever been evaluated for any type of psychiatric treatment before? Have they ever taken any medications? Have any of them worked in the past? Have any of them not worked in the past? Have they ever engaged in therapy? We need to establish our baseline of what are we coming in with, all of what we can get with their history and their background. So, you know, I will say across the board, something that I talk about with all my patients, whether they're coming in for suicidal ideation, homicidal ideation, schizophrenia, no matter the diagnosis, one of my biggest things that I personally talk about with my patients is positive coping skills and building positive coping skills, because I think as a whole, that's something that people are lacking. A lot of times that's why people turn to negative coping skills like drugs and alcohol or whatever it may be. And so a lot of times I think one of the biggest parts of having a successful treatment plan for somebody, not just while they're in the hospital, but once they're discharged, is having at least one positive coping skill that they can turn to for when they're dealing with something difficult with their diagnosis or in their life. And I really think that is a priority that I work on with my patients while they're in care, and they have the supportive staff of building that coping skill that they don't have to rely on anything external for. And so that is my big thing personally.
Give me some examples.
Yeah, so I have a lot of patients who are resistant to this idea at first because a lot of times they're like, well, my positive coping skill is going and playing basketball and I can't do that here, or whatever it may be. They kind of push it off. But I always explain to my patients, again, let's find a positive coping skill that you don't have to rely on anyone else or anything else for, so that you can do on your own, anywhere, anytime. So a lot of those would be grounding techniques, and that helps a lot with my patients that are in psychosis and active psychosis, of kind of regrounding them to where they actually are. A lot of times it's just deep breathing with a lot of people that have anxiety. I also am a big advocate on just any type of body movement. And so we do have different groups and stuff like yoga, or just I always advocate just to get my patients outside whenever I can, just because I think movement of any kind just helps release a lot of energy that they might be having that's negative. And so I think another one with body movement is a great tool that they can use. And so those are the three examples I usually give them. And usually patients will like one of those. If they don't, we'll figure something else out. But I really do believe that is something that needs to be a priority in someone's care, and not just in someone's care when they get to me in the psych unit. I think that's something that helps with prevention. And I think that's something I see with the youth a lot, is a lot of them have no coping skills. And so when they have no coping skills, they have a hard life stress event and they don't know how to cope with it. And so instead of being able to cope with something, they decompensate because there's nowhere else for them to go, because they don't know how to cope with a hard life stress event. So That's a big thing for me, treatment-wise. I think that's a big priority. And then sometimes they need meds, sometimes they don't. We don't do a lot of therapy in inpatient psych because they're not stable enough yet, typically. So the priority is very much acute stabilization.
Wow.
And typically therapy comes when they're a little bit more stabilized. So people ask me that a lot. They're like, don't you have a bunch of therapists on your unit? And I'm like, actually, no, not really. We have like group therapy and stuff, but individualized therapy, it's too much too soon for patients when their big focus is, how do I get out of bed? How do I brush my teeth? How do I... The big focus is very much how do we get them back to performing their activities of daily living safely and appropriately and without risk to themselves or others. So,
wow. So you have situations that people don't get out of bed.
yeah.
I guess that's why it's called high acuity unit,
Yes,
right?
yeah.
Well, Yianna, thank you so much for doing what you're doing. This is hard work, and thank you for sharing about suicide. It's not a light topic at all, but we do need to educate ourselves. How can we help someone differentiate between normal stress and clinical illness?
So I think this is a very important topic. I kind of mentioned the younger generation not having very good coping skills. And I think part of the problem is this topic. I think with the opening of the conversation of mental health being more prominent, which I think is a great thing, I think the only con that came with it was it being kind of oversaturated and it leading to a lot of self-diagnosis based off social media posts. For example, I'll say with even my social media platform, I always have a disclaimer that this is educational content only, not medical advice. And I always encourage people, if they want to look at medical content, it should be a starting point where you get all of your advice from, your clinical and medical education, like for yourself. You should always be seeing a provider for this kind of intense stuff. But I think it's good to educate yourself too and see it as an educational opportunity, but not to live your life off of. And so I think that's an important distinction that needs to be made with social media as well, because there's a lot of misinformation out there. And so I think what happens with self-diagnosing, especially with the younger generation, is, I'll give you an example. I had a 12-year-old patient once who came in and she was like, well, I'm depressed because my boyfriend broke up with me. Okay, that's hard. That's difficult. But is that clinical depression or is that you not being able to cope with the hard life stressor? And I could give you a lot of examples like that. The difference between normal stress in everyday life and clinical depression is normal stress is going to be tied to a specific situation and something clinical of mental illness is going to interfere with your daily living for a chronic period of time. And that's one of the first ways that you can differentiate between a normal life stressor, life is hard, things come up, and something that's going to be diagnosed as something clinical, like clinical mental illness. And so, unfortunately, I've seen a lot of times this lead to over-medicating people. Is this not being able to manage regular things in life that come up and hardships that we need to learn how to manage with positive coping skills and support systems and a little bit like toughing it out? And then there's clinical mental illness. And I think that gap is very important and that distinction is very important because that self-diagnosis can lead to over-medication, improper diagnoses, and actually making people worse. So if they don't have a diagnosis, we don't need to be medicating them.
Yes. So maybe that's where the whole idea of America is over-medicating came from.
Potentially, yeah.
You know, because people don't have basic life skills and they come up with this self-diagnosis. And
I do see it as an issue in my practice. That's why personally I'm very big on care plans, and this is hopefully something I will keep to when I become a nurse practitioner, is building positive life coping skills, building all these other aspects of your life in this structure. And then if you also need meds, we'll figure out the meds. But, you know, my priority is not going to be meds, not look at anything else going on in your life. I personally don't agree with that approach.
Yeah. Thank you for sharing that. What have you learned from your patients?
A lot. I think my patients have really humbled me in a lot of ways. The biggest thing I'll say is I get to see a lot of courage and strength in a lot of them taking the first step in getting care. And that says a lot because most of my patients come in on legal holds, so they don't want to be there. So initially when patients get there, they are very resistant to any type of treatment, but they don't have a choice in being there. So it really takes a lot of self-reflection and humility for somebody to at some point give in and say, hey, like, actually, I might need some help. And seeing that is humbling for me and I think shows a lot of strength and courage that they want to like get to the next step and progress and
Get better,
get to the life they want to be living and get to the next step.
What's a legal hold? I think I understand, but I want to...
Yeah, so in an inpatient psych unit, my patients come to me on a legal hold for either danger to self, danger to others, or gravely disabled. So danger to self is typically a suicide attempt or self-injurious behavior of some kind. Danger to others is typically homicidal ideation or they assaulted somebody. Gravely disabled is somebody's mental illness is so decompensating for them that they are not able to care for themselves or others. And so I get all three. And in the state of Colorado, it's called an M1 hold. When I was practicing in California, it was called a 5150.
Interesting.
In the state of Florida, it's called a Baker's Act. So depending on the state, they're all called different things, and they have different stipulations of what constitutes somebody to be placed on a legal hold and how they get off one and how long they can be extended for and all those different types of things. But that's typically what brings somebody into a psych unit. I do sometimes have voluntary patients who will admit themselves and say, hey, I'm not feeling great. I'm worried about what I might do. Can you admit me? And you legally have to admit somebody that says something like that. I have some vol patients, but that's not the majority of the patients that are on a psych unit.
How's your faith helping you in the trenches?
Yeah. Yeah. A lot of times people ask me how I do this job and stay sane. So I think part of that is my support system that I have and my strength and my faith. And I don't think I could do this job without both. I think I have a solid foundation with both of those things. And, I even think my prayers have shifted as I've been in practice. And I've always prayed to St. Gerasimos, who's the patron saint of mental health. I've prayed to him since I was in school. I continue to pray for him, for my patients on a daily basis. I always pray, one of my specific prayers that I pray that I can be a vessel of support for these patients and be what they need to help with their care. And I think that is something that helps me with this job too. But I really think that I see so much of God within my patients, and that I really I couldn't imagine not being a faithful person doing this kind of work because I do see so many hard things on a daily basis. And I think, honestly, I don't know how people do it who don't have faith.
Yes.
They do it somehow. I don't know.
Yes.
But I think that's the only reason I'm able to do this job with such optimism because I do see a lot of negative stuff on a daily basis. But I don't go home feeling negative. I go home feeling fulfilled because I was able to help somebody in their most vulnerable time.
Yes.
And that's another thing people ask me. They're like, how do you not go home and be just depressed all night? And I'm like, because I don't look at it that way. I don't feel like that. I feel like I was able to help somebody at their worst time. That's a big deal. That's like an honor and a privilege to help somebody in that time period where they were really struggling. That to me is an honor. So I don't look at it like that. I don't feel it like that. So, but I attribute that to my faith and the strength I have in my faith in God and strength of my family and my support for my family. So,
and I know for sure it takes humility to have that type of prayer. Lord, please help me be whatever my patients need me to be for them. Obviously, it's very important to know your scientific facts and the medication and all that stuff, but I think making yourself available for God to work through you for the specific need of the patients, I think it requires a lot of humility because it requires you to get out of the way, in a sense, while you are using your brain, of course, and your knowledge that you are working so hard to still acquire after all these years. I think it's inspiring, and I think it takes humility to just get out of the way and become whatever that patient needs. What do you hope to see for the future of mental health, both in society and in church?
So I think in the church, having more trauma-informed care and opening that conversation more, which I am seeing. We talked about O-Camper. We talked about interconnecting faith and mental health. So I think that is something that's on its way, but there's always more to be done.
Of course.
So I think that is a big thing in the church. And I think in society, continuing on with bridging that gap between what's actually going on in psych care and what people think is going on in psych care. Because I think even with this openness of the conversation, there's a disconnect. And that is something that I see in practice and then I see out in the world. And even with people that ask me questions about what I do for a living, they have maybe a misconception about what I do, the types of patients that I treat. And so I still think there's a lot of work to be done with that as well. I always kind of say to people, my patients are normal people. I have patients that are probably your coworkers, or people you go to the pool with, colleagues, whatever. You would have no idea that they're dealing with this kind of stuff. I treat doctors, lawyers, other nurses. You have no idea. And when I say that to people, they're shocked when I say that, because people have this idea in their head that it's always just some, quote, crazy looking person. And that's not the case. These are normal people living their everyday lives, having a different type of struggle than you. But that's it. That's all it is. Like the same way people have diabetes and asthma, we're just treating a different part of their body, their brain.
Thank you for normalizing this, because I think in religious environments, there is this specifically attached to mental illness or struggle. It doesn't have to be a diagnosed illness, just a struggle. There is this stigma around mental illness that most people think something is wrong spiritually with a person, but not many people say something is spiritually wrong with you if you have a liver disease, for example.
Right. No, 100%.
So, thank you for sharing that. I am even shocked. The picture you are painting about treating lawyers and doctors, you don't think about it, in that way. Well, let's end maybe by you addressing someone who is struggling right now. What did you say to them? Let's say I'm coming to you and I'm saying, I'm struggling with suicidal thoughts. I'm struggling with anxiety. I'm having a hard time coping with life. What is your message for people who are struggling?
The first thing I would say to somebody, and this is another thing that people can use if they find themselves in this situation, is thank you for telling me. Thank you for telling me. And I think that opens the door for the conversation to just go from there. Thank you for telling me. I tell a lot of my patients, a lot of them get caught up in diagnoses a lot of the time and like a label. So I talk to my patients a lot of the time about, you're not your diagnosis. Let's figure out what we need to do to treat the symptoms that bother you the most. Let's figure that out. Let's figure out what we need to do to get you back to the things that you love doing. Let's not focus on this label. Let's not focus on this diagnosis. You are not your diagnosis. So that's another big part of it. Again, I would reiterate, there's strength in your struggle, and I see that on a daily basis, and that's, again, why the Phoenix is my logo on my Dynami page. I would say to you, God is not ashamed of you. He's here for you, and he will walk with you side by side in your suffering. You're not alone in this whatsoever, even if it might feel like you are, and speak up if you can. If you can, really do your best to speak up, because that can make all the difference in getting you the care and support that you need. And there are many people out there like me who are just wanting to help you. So we're out here.
Yes. Well, Yianna, thank you so much. Our time together has been way too short for the many topics we could talk about. Thank you for being here.
Thank you for having me.
Truly, it's an honor. I've known you since kindergarten, and it's been my honor and privilege to watch you grow up. I know you've had your share of struggles, and I admire your resilience and your passion for serving. It's obvious that you are very passionate about this. Thank you for being there in the trenches, co-suffering with those who suffer, as Christ commands us, and for everything that you do. I'm hoping we can come back and do some more episodes together.
Yes, I'd be more than happy to. Thank you for having me. I appreciate it.
Thank you, Yianna. We did it! Good job.
That was awesome.
Thank you for joining us on this powerful episode of the Bible Chat podcast. A special thanks to Yianna Papadeas for sharing her incredible journey, insights, and passion for psychiatric nursing, as well as her heart for bridging faith and mental health. Her work reminds us that there is strength in struggle, and that compassion, education, and open conversations can make all the difference. If you or someone you know is struggling, please know you are not alone. Reach out, speak up, and seek support, whether through a trusted friend, family member, or resources like the 988 Suicide and Crisis Lifeline. Let's continue to break the stigma around mental health and build communities that are trauma-informed and filled with love. Follow Yianna's work on her platforms Dynami and Overheard in Psych for more insights and inspiration. Until next time, may we walk in hope, courage, and grace. God bless.